Let's invite Dr. Dilip Pawar to talk on dealing with premedications, dealing with mom, dad, and the baby. Dr. Pawar.
Thank you, Professor Kamege. I'll be in the next couple of minutes dealing with what you do every day. So what we'll try to do is to share my approach to this. Because in children, when you deal with a child, it's unlike adults, you deal with a family. It's not only the child, it's the family, and you have to deal with both family. How do you change? Pointer? Okay. How do you change? Okay. So, whole purpose of dealing with family and meeting the family is to understand them and help them, or they help us to provide the best possible anesthesia care. And what we evaluate in the child, we evaluate the anatomy, physiologic and pharmacological aspects of a child, and basically primarily to evaluate the risk involved when the patient comes for surgery with primary disease or comorbid conditions. All these we know when before approaching the child. When you look at the case folder or case file, we know the patient's history, including the previous anesthetic history, any difficulty, size of the tube, any complications like bronchospasm, laryngospasm, sensitivity, or any adverse reactions in the theater. The patient's examinations findings, all the investigations we know, and you know the comorbid conditions and the primary conditions of the child. So before reaching the patients, approaching the child and the family, we know most of these parameters that's going to determine the risk of the child. Routinely, there are certain investigations we used to be carried out, BT, CT, urine, no more done. Presently, for minor procedures, most of the investigations are not needed. In our country situations, probably we do hemoglobin routinely. For major cases, it has to be a complete evaluations. And neonates with congenital pneumothorax, they have to be an echo. Hemoglobin is a very interesting, in our time when we started resident, 10 gram. I had a colleague who were working together, postpone a case of tongue tie release because hemoglobin was 9.2 grams. So that's not practiced anymore, a rigid criteria. With the understanding of physiological understanding of principles of normopolymic hemodilation, we know the children can manage 7 or 8 grams, and there's no need to postpone these cases for minor surgical procedures. If they are on drugs, which is likely to affect the myocardial functions, you must do an echo and properly evaluate them. What we don't know from the case file is the surgeons don't assess the airway. They probably don't have an assessment of the venous access sites or the block site. These has to be done when you meet the patients. When you are ready to go to the patients to meet the family, the primary goal of our preoperative visit is to develop a rapport with the child and gain the confidence of the parents. There is absolutely no other aim because we know the risk involved in the preoperative period from the case file. Dealing with the mom. Which mom we are talking about? These are the moms who work in a very close to nature, very hard life. So they're quite used to the hardship of life, and life has taught them how to deal with difficult situations or hard situations. So coming to a surgery or coming for a surgery is not a great deal for them. They can cope up with it much easily as compared to others. And they accept you as they trust you more. They have more confidence in you. They will take care of the child. Their only concern is, will be child all right after the surgery? This is the second set of moms. They are city dwellers, educated, working. They come with a file folder with all downloading the internet, all about the surgery and anesthetics, complications, and they'll have many, many questions. And many of them will be part-time mothers, means not available for the child all the time. They indulge the child because they have the guilt of not looking after the child all the time. So dealing with these parents, mothers, and the child will be slightly different than dealing with the rural child and parents. This child will be much more delicate because the rural child will be hardy. So dealing with them was slightly different in this sense. But these parents are much more helpful if you bring them into theater. They can understand your issues, they can be cooperative, and they can helpful in the theater much more than the other group. You have to earn a confidence. They will be more asking. They have to sort of develop a trust with them. They have an anxiety, and this anxiety of the parents usually reflects in a child's anxiety. So the child will be more anxious if parents are anxious. So if you talk to them nicely and allay their fears, it's much better. Sometimes in our country situation, children are looked after by grandparents. When the grandparents or grandmothers look after the children are much more confident, much more affectionate, and they can deal with hard situations much easily. Dads, talking about dads, they are cool guys. They don't bother much. They let the mother do the talking and discussing. They are into more logistics. In the West, preoperative preparation programs are quite popular, or used to be, and they definitely in literature showed a reduced anxiety on the day of surgery, but they all vanish at induction. It's something like, you are very good in a simulator, but when it comes to patient, you start sweating, right? So with these programs are slightly becoming redundant because the more and more cases are being operated in daycare basis, and you have hardly any time to spend with them. So you have a very short time, most effectively use that time to prepare the parents. In fact, there are a group of, this is a meta-analysis where they looked into web-based behavioral programs to help the mother and child cope up with these surgery situations better. Then how do I approach the child? First, you have to prepare yourself. There are three things I always insist: the attire, the attitude, and the conduct, how you conduct yourself. You have to be confident, even if it's the end of the day, you are tired, you have to rush home, you had a fight with your colleague, or you had a sort of a alterations with the consultant, a problem with the consultant, you had a complication theater. Still, you have to maintain your composure and happily approach the child. The appearances do make a difference. If you are going with a pleasant appearance, the child instantly recognizes as somebody who's caring. Whereas you will very casual dress, you have to earn that. You have to be caring in attitude. Approach child with caring attitude. Love is a very important component in life. And so it is in your preoperative interaction with the family and the child. The child has a unique ability. The child can perceive the vibrations generated by your thought and your body. When you go home and look at your child's behavior, you understand what is mood you have. You are worried, you are sad, you are happy, will reflect your child's behavior. They can appreciate. So when you approach the loving approach to the child instantly develops a rapport with you. When you go to the child, whom do you approach? If child is less than 6 months, talk to the mother. It's more than 6 months, talk to the child. If you talk to the child and you develop a good rapport with the child, parents are satisfied anyway. You don't have to talk to them much. Then how do you introduce yourself? Introduce yourself Don't talk about surgery and anesthetic. Talk anything else. Sports, games, school, anything. And talk to surgery later on. Once you develop a sort of a simple communication, then you can explain everything, examine veins, airway, chest, heart, everything you can do, and they'll be very cooperative. It's very, in most of the cases, it's not difficult to develop a rapport with the child. At least, except in certain situations where a syndromic child, you can't develop a rapport because child has a language barrier, introvert child has previous unpleasant experience, has a multiple surgery, or not familiar with the environment. In these situations, how to deal with these situations? They are either you deal with them in a child-specific area, or pre-op area, pre-op hold area, or it is something which is much friendly, or parental presence at induction or premedication. Parental presence has become very popular. In our country, it's not yet. There are very few hospitals who allow the parents to come in, but it's a great if they're helpful. But you have to be very choosy sometimes. I've seen parents collapsing at induction after seeing the child going up. I've seen father giving a disgusting look at the anesthetist when he can't get a vein for 3 times. So you have to be very careful, choosy as to which one. And then when you give the POP instructions, it has to be very, very clear, precise, and I insist on a bath. And my approach to NPO is different. I prescribe feeding. Say no meal after 10 o'clock, give a feed at 8 o'clock or 4 o'clock or 7 o'clock, depending on the time. What fight? How much is normally prescribed? Then why do you premedicate? Early anxiety, decreased secretions, they're all textbook languages, but primarily it is to early anxiety. Because you see the literature on premedication is so vast, so many drugs, that means we haven't found an ideal one. Most of the premedications used they don't work effectively in all the patients, right? Most common one which is used in children are midazolam, right? But you have to have a quiet area after if you give to premedication to the child. Other drugs used in the literature are ketamine, chlorhydrate, clonidine, and dex. Ketamine and chlorhydrate have slightly gone out of fashion, but clonidine and dex looks a good potential, but they are mostly confined to literature, not very commonly used in practice. This is a study on clonidine, and you see the fear of heart rate decrease and blood pressure is slightly not unfounded, I'll say. And you see in this study, when there's such a large number of patients, there hardly incidence of heart rate is very low. Dex is quite effective as compared to midazolam, but still these drugs are not effectively used. And midazolam is the drug of choice, except it's very bitter. Because bitter, people use ruafza, honey, all sort of combinations. I prefer use paracetamol syrup combination, which gives a good post-op analgesia as well. Thank you very much.